So thank you, Pedro, for the kind introduction. Also, thanks to Nestlé to invite me here. I'm here to talk about techniques to assess muscle health and sarcopenia in clinical setting. I would like to start with a question to the audience. Are there people here present today who like geriatric patients? Raise your hands. I'm going to make a controversial statement. I am a geriatrician, but I strongly dislike geriatric patients. I don't hate them, but I really dislike them. So my dream or my ideal day would start with coming on the ward and not seeing any geriatric patients. Today I will talk about landmark articles, landmark documents. This will be not what I'm talking about, but this is an interesting one. When I thought about landmark articles in England, of course I thought about the signing of the independence of America. It was a document with a lot of information, but nobody knew what would happen after the signing. So big question marks all over the place. And the same thing we saw when the sarcopenia landmark articles in 2010 and 2018 were published. I remember in 2010, everybody was super enthusiastically because now we had like a guideline. We could see sarcopenia, we could diagnose sarcopenia, and we were going to change the geriatric world. We didn't. So in 2018, another attempt was made, and in 2010, we had like a clear guideline, a clear flowchart, but a lot of measurement points, a lot of cutoff values. So in 2010, we said, well, we'll screw up the flowchart, we'll make it much more difficult, and we'll make the cutoff points easier, to keep the balance. Why do you say we screwed up the flowchart? Because the point where we can confirm sarcopenia, not think probably it is sarcopenia, but to confirm sarcopenia, you have to look at muscle quantity or quality, and you use like whatever. You use DEXA, CT, BIA, MRI, just do whatever. But that's the funny part, we won't give you cutoff marks. We won't tell you what muscle quality is. So it's really unclear what to do. And I think the next necessary landmark is which measurements should we be taking? Certainly on a theoretical point of view, this was a great step forward because we said, well, we need to imply some quality measurements. So theoretically, it's very good, but practically, I'm a very practically oriented physician. This was terrible, because what do we need to do? Which techniques do we use? Which cutoff points do we use? So the thing is, perhaps we're making it too complicated. Are people here thinking that, muscle quality isn't important, we just need muscle quantity? Let's see some hands. We just need muscle quantity, just measure quantity. No one? Everybody's convinced that we need quality? Okay, perfect. So DEXA and BIA aren't perfect for the job. So we do want to make it complicated. We agree as a whole, this room, we want to make it more complicated. Okay, perfect. So if you go for muscle quality, and you all want to go, you wanted to go there, I didn't want to go there. So you want to go for muscle quality, we have to look either at architectural properties or force generating properties. It's part of the same thing. When I was making a presentation, my daughter was helping me, or thinking she was helping me. And I said, we need something that's the same but very different. And she's now into Harry Potter, so I used, people who know it, Gryffindor and Slytherin, they're always fighting, but they're part of the same team. And looking at muscle quality, it's very difficult. Because you've always had the two people fighting. No, muscle quality is just pure architecture. And people say, no, it's the other way around. And this is a great article. If you want to read something tonight, if you're bored, read this article. And it's defined as muscle quality, the amount of strength or power per unit of muscle mass. Now, it's a very good definition, but if you look at the different subcategories of quality, you see that there's force production, contraction, relaxation, metabolism. Metabolism is very important, but substrate turnover, storage, heat generation is also very interesting. Why do our geriatric patients don't get fever as often as younger patients? It's probably a quality problem. Myokine production, electrical conduction. So a lot of things, and even when we're speaking about muscle composition and muscle quality, we're not even talking about the whole thing. We're just talking about changes within the muscle itself. So probably because we don't know which components are useful, which components do we need to choose, which are more clinically important, and which changes occur first. So in our process, when I say I dislike geriatric patients, and I really mean that, what we do is we look at patients and we say, well, you're not ready for geriatrics yet. You're too good. We'll wait until you get worse and worse and worse. And when you can't do anything anymore, when you're lonely, when you're malnourished, when you can't walk, then you can come to us. But you have to decline before we try to get you better. So this is the problem. At what point in time will we say, well, this specific component of muscle quality or quantity or whatever is so bad that now we can treat you. And now we will see you as a geriatrician. Just to say, I won't even talk about this one. If you're really bored tonight, you can read another article, Sarcopenia, Neurological Point of View, which is very interesting, but is way beyond whatever we're doing with sarcopenia right now. So this is like Star Trek 2900 or something. If you look at the different measurement tools we have, you have DEXA, BIA, CT, MRI, all proposed in a 2018 article. And we'll just go through them one by one. If you look at quantitative measurements, we know DEXA, BIA, CT, MRI can give you quantitative measurements, which is perfect. But in 2018, they told us we need to measure quality also. And we all agreed that quality is perfect. So we know DEXA and BIA, we cannot use it anymore because it will not give us the information we need or we want. So we have to resort to CT or MRI. But if you look further, everybody has a CT in their hospital. A lot of people will have an MRI in the hospital. But I'm not sure if you call the radiologist and you say, well, you know, I'm looking for sarcopenia. Can I do an MRI today? It's urgent. I'm not sure how many people will get an okay from their radiologist. And it's certainly not available bedside. I never asked, you know, if you take a radiography at the bed, it's okay. If you want to use an MRI at the bed, it's very difficult. So that's not feasible in clinical practice. Also, it's totally unstandardized. If you look at the reference values, we have reference values for DEXA. We have some reference values for BIA, but there's a lot of discussion with certain age groups. So there are different definitions for BIA cutoff points. But for CT and MRI, it's totally absent. So all the techniques that are prescribed in a 2018 article cannot be used in practice, which is a problem. So there was a day I disliked geriatric patients so much, I thought, well, I have to, you know, think about something else. And then we were thinking about ultrasound. And ultrasound can give you quantitative measurements, qualitative measurements. I'll show you a few examples. It is available in the hospital, and it's very easy to use bedside. I have like a mobile device I can use on my cell phone. We worked very hard for the past 4 or 5 years to give it some standardization. The only lacking now are reference values. It is a reliable technique, and it is becoming increasingly prevalent. It's low cost, it's safe, it's portable. You can do it every time, every day, 6 times a day, and the patients won't feel a thing. Can't do that with a DEXA. Can't do that with a CT. Doesn't emit radiation, so it's very attractive for repeated use, and it has demonstrated high reliability in many studies. There are 6 parameters we do so far. So muscle thickness, cross-sectional area, fascicle length, pennation angle, intensity, muscle stiffness. We do some compound measurements. This is one of my colleagues who's very interested in muscle stiffness. I promised to show her also because she's working very hard. Sophie's in the room, thank you very much. She's doing all the work that I'm not doing with geriatric patients. Muscle thickness. It's a measurement you can get in like 5 seconds. It's very easy. A lot of articles saying, well, if you just measure diaphragmatic thickness, it's a predictor in intensive care for mechanical weaning. You can take 5 seconds to look at muscle thickness and have a correlation with strength and functional capacity in older adults. If you have 5 seconds spares, you look at the psoas muscle, you can give an outcome on lumbar fusion surgery. This is just hand-picked articles from many articles that are available, literature. And some specific things. I don't do tongue thickness. It's, well, you know, I don't like saliva on my machine, so I don't do it. But it's linked with masticatory performance, and it's linked with malnutrition. It takes you 5 seconds. For dysphagia, we described some swallowing muscles also, that if you measure them, it takes a little bit more time because they are very small muscles, so it takes some time to be really sure. But it can give you an idea of dysphagia. It is not invasive. It's very easy to measure once you get away with it. It's very easy to predict sarcopenia. Another measurement is cross-sectional area, so you use the same point on the muscle, but just counterclockwise, turn your probe. It's associated with degree of myostetiosis and can be used as a prediction of mortality in cancer patients. It can be used to predict strength and outcomes in people with COPD. It can be used just to say there are many different kinds of patients you can use it in people undergoing specific kinds of surgery. Fascicle length, something you can calculate, so it's not something you need to measure per se, but it's very useful in, for instance, the use in post-stroke people to see what change, and it gives you some idea on outcomes. The pronation angle, which is very interesting, but I think some research has to be done before we get really to the core of pronation angle. What we know so far is that it's a very good association with strength. So if you don't have like a Jamar measurement, which is of course very easy, the changes in pronation angle can give you a lot of information. It also gives you a lot of information about sarcopenia. This is a large Chinese study, so it's done all over the world. And it's very good correlated with measurements of sarcopenia without the use of DEXA via CT or MRI. Echo intensity is really interesting. This is a study, I think, 17, sorry, done in Japan, and it gives you an idea of, I'll just try to go back. Just looking at the echo intensity, you can see if patients are, normal, pre-sarcopenic, sarcopenic, which is very interesting, but I have to say, it reflects muscle strength. I was going for another one. So these are ultrasound images of my leg. It's after corona, so it's a lot of fat tissue in there. Don't mind that. But it's the same picture taken, the same moment, different settings on my ultrasound machine. So this is like a generic ultrasound machine, and it has 3 points in which you can change your settings. So if you read studies about echo intensity, you have to be very careful to interpret the results. Muscle stiffness, and if there are any questions about muscle stiffness per se, she's the she's the go-to girl after the presentation. A lot of different techniques that can be used. There's a very good review we wrote a couple of years ago, and it's correlated also very good with physical function. Just a simple measurement. It takes you, well, not 5 seconds, I think this will take you like 1 or 2 minutes. The compound measure from Marcus Narici, for instance, it's a compound measurement of taking just the fascicle length and the muscle thickness, and it correlates very well with young people with sarcopenia, pre-sarcopenia, which gives you a very good idea of like a continuum over time. Just 2 very simple measurements who can be done within 20 seconds. So there's a lot of potential. And we all know, if you read about sarcopenia, if you go to PubMed, you say, well, sarcopenia and ultrasound, you see it's booming. It's absolutely booming. But what we need is more standardization and more reference values to really get it through. So some small commercial announcement for Sarcus, which has standardized measurements in ultrasound sarcopenia research. So last year we published the 2020 update, which was published in 2021 due to Corona. in which we describe 39 different muscles. So there's something for everyone. There's something for people interested in dysphagia, in physical performance of the lower leg, upper leg, neck musculature, back musculature, abdominal muscles, diaphragm, whatever you want. We did it. This is one of the tables, so you can see at which point exactly do you need to measure, what are the pitfalls, how do you keep your hand. For people interested, we also have a YouTube video if you want to see how to do it. It's like the basics, it's very simple. My 8-year-old son did like the camera work, and I let him train with the ultrasound device, and he did perfectly. So you can probably also do it. Yeah, absolutely. We need reference values. There are some studies coming out. We have had like a small study in biceps, because imagine walking through the shopping mall or the shopping streets in the town where you're from. It's very difficult to say to patients or to people, well, you know, drop your pants so I can check your quadriceps. It's not really done, you know? Certainly not with women. Men tend to find it's funny, but women don't. So we tried a different measurement, and we say, well, can we measure your biceps? Just look at your biceps. I want to have like 20 seconds with your biceps. If you check it, it's just one measurement, so it's not perfect. It's a correlation value of 0.6. So we're working and looking into, do we need more data? Do we need different age groups? Do we need to see a change over time? Because if you were to go to every patient that's pre-retirement, between 60, 65, and say, I'll just measure your biceps, 20 seconds. And I see that they hit a certain value, then I can say, well, perhaps now is the time to give you nutritional supplements, because we all know that nutrition is paramount. You all know that exercise is paramount. If I scare the 60-year-old, she will become a much more fitter 70-year-old, and hopefully doesn't become the geriatric patient I so dislike. Because the ultimate goal is not, hating geriatric patients. That's not what I mean. The ultimate goal is measuring the 60-year-old, so he doesn't become a geriatric patient. Why are we waiting for people to decline before we want to treat them? I think 80% of our work is 20% of our results. We need 20% of our work in those younger patients, or pre-patients, to get 80% of outcomes. And that's the same for osteoporosis. It's shown yesterday also, I think, by Alfonso Cruz. We need a stepwise method, not just green or red. Those 60, 70-year-old patients are in the yellow zone, and we don't screen those patients. Why not? They're not geriatric patients. But if I screen my patients, I know they're all sarcopenic, and they won't take their nutritional supplements, and they won't do their exercises. It is very frustrating. They don't care anymore. But if we scare a 60-year-old, they say, well, your parents are not doing very well. We should treat you. I speak as often to the daughters and the sons of the patients who are coming in for the consultation. They say, well, you should be doing what I'm telling your mother. So treatment plan, we're on that. I won't go in detail here, nutrition and exercise. Just a very small thing. Just to show again how easy it is. It's a very good article, very recently published. It said, well, if you measure masseter muscle, it gives you a very good idea of malnutrition. So malnutrition is very difficult. We have the MNA and we think we know it, but it's like you're probably malnourished, or you have risk for malnourishment or whatever. It's like saying, well, my car will or will not break down today. I'm not sure. But if you measure your masseter muscle thickness, for every millimeter in this study decrease, so the risk of sarcopenia increasing by 60%. If you just go for the same shopping mall or shopping street or whatever, and you're just measuring masseter muscle, it takes 20 seconds. Give a very clear estimate of the risk of malnutrition without doing all the questions. This study that will come out, I think, next year. It's an industry-sponsored thing, I think, nutritional ultrasound. So this is something we'll have to see next year. And in conclusion, ending very much in time, unlike next time Pedro asked me to speak, there is a lot of potential. And the potential at this moment is in assessing different muscle components. And this means easy screening and easy diagnosis. I think we will have to implement and look into what do we have to do for the future, and certainly for assessment of problem areas. So take-home messages, we have to think about where we're going. We all want to measure muscle quality, but nobody's really prepared to do it so far. And it seems the next big issue to tackle, regardless of the specific treatment regimes we have. And ultrasound can be a helper in, but we have to choose what we want to measure. So GLIS is one of the initiatives that was launched also yesterday. Alfonso talked about it a little bit. It's really an international collaboration, and I hope there we will have some answers instead of more questions. So thank you very much.